topic of lecture is classification of caries cavities by Black, basic principles of cavities preparation, stages, and peculiarities of the conventional preparation of caries cavities, depending on the class, modern methods of caries cavity preparation for composite materials restoration, and alternative methods of cavity preparation. Lecture outlines: definition of dental caries, classification of caries cavities by Black, objectives of cavity preparation, Black's principles of cavity preparation, modern methods of caries cavity preparation for restoring them with resin composite, alternative methods of caries cavity preparation. Prior to start conversation about dental caries, tooth decay, caries cavities preparation, it is worth to mention about father of dentistry, father of contemporary modern dentistry, and it is Sir Greenwardiman Black. In 1908, in USA, Greenwardiman Black publishes his monumental two-volume treatise Operative Dentistry, which remains the essential clinical dental text for 50 years. Later, Black develops techniques for filling teeth, standardizes operative procedures and instruments, develops an improved amalgam, and pioneers the use of visual aids for teaching dentistry. Here I put his famous statement, and he was like a predictor, possibly. And these words are such: the day will come, and maybe we all live to see it, where we will practice preventive instead of reparative dentistry. And every dentist struggles to follow this statement, but still we have tooth decay, and still we have reparative dentistry. Definition of dental caries. So, tooth decay, it is a synonym to dental caries. It is an irreversible microbial disease of the calcified tissues of the teeth that occurs after their eruption. It is characterized by demineralization of the inorganic portion and destruction of the organic substance of the tooth, which often leads to cavitation as a result of local and general reasons. These diagrams gives you a simple idea of etiology of tooth decay, and this is a modern concept. So we have such a diagram in which we have a few components. The first one, it is microorganisms that persist in dental plaque. The most cariogenic of them is Streptococcus mutans. Of course, tooth tissue, susceptible surface. Host surface, it is that place where plaque stay for a long time, not being disturbed by a toothbrush, and that's why that is the place where plaque accumulates. These places are proximal surfaces, natural pits, fissures, cervical areas, occlusal surfaces. The next component that influence development and progression of tooth decay, it is diet. Diet that is rich in fermentable carbohydrates, easy digestible carbohydrates. Such food as candies, sweets, chocolate, numerous intake of it, constant intake of such food will lead to accumulation of plaque on the tooth surfaces. And of course, do not forget about time. Time, it is that component that plays essential role, because all these components should co-interact for some sufficient period of time, such period of time that is enough for all of these components to do their harmful effect. So these are components etiology of tooth decay. And this is outer circle, it is saliva. Saliva, it is that environment in which teeth and other organs of oral cavity stay all the time. That's why saliva plays essential role in either progression of tooth decay or remineralization of tooth tissues. Such criteria we take into account when we talk about saliva. It is its pH, buffering capacity, composition, and flow rate. If everything is okay, there will be remineralization, there will be prevention of tooth decay. But if some of these components or buffering capacity or flow rate or composition of saliva is not in the normal condition, so there will be tooth decay progression. That's why saliva plays essential role in caries prevention or progression. The next issue that should be discussed on this lecture, it is classification of tooth decay. So we use several classifications. And in this lecture, I accumulate that classification that is used in our country, that is used in Ukrainian study system. So the first one is clinical. We have, according to it, initial caries, it is white spot lesion, superficial, medium, and deep. According to anatomical classification, caries is divided on caries of enamel, caries of dentine, and caries of cementum. Classification that is based on localization. We have caries of fissures and pits, proximal surfaces, cervical area. Classification that is based on severity of disease. Caries can be acute, chronic, rampant, secondary, arrested. Classification of tooth decay that is based on intensity of the lesion. So tooth decay can be compensated, subcompensated, decompensated. By the way, these photos describes secondary caries and rampant caries. So secondary caries, it is caries that develops around existed restorations, as in this case, old restorations usually has a problem that around them there is a micro cracks, and in these micro cracks can flow microorganisms, and as a result there is a secondary caries. By the way, in another classification, European or USA classification, tooth decay is classified in primary and secondary. But we do not use such classification. But still, you should know that caries is classified in primary and secondary. So primary, it is that caries that develops that was noticed for the first time. Secondary caries, it is that develops around existed restorations. And here is rampant caries. So rampant caries, it is numerous caries cavities that occurs on different group of teeth at the same time and on few surfaces of one tooth are affected. As you can see, anterior teeth, cervical area, proximal area. Here we have two surfaces affected of anterior incisor. So that is rampant caries. Numerous caries cavities on a different group of teeth affected different surfaces of the teeth. Classification that is based on the presence of complications. So according to it, the caries can be simple and complicated. And finally, Black's classification. So according to the Black, it is outlined 5 classes. Class first, tooth caries cavities that develops on fissures, occlusal surfaces, pits, on all group of teeth. Pits and natural pits usually located on the palatal aspect of anterior group of teeth, mainly lateral incisors of maxillary, and buccal surface of posterior group of teeth, both mandibular and maxillary teeth. Second class, caries cavities that is localized on the proximal surfaces of posterior group of teeth. Class third, caries cavities that is localized on the proximal surface of anterior group of teeth. So posterior group of teeth, it is molars, premolars, and anterior group of teeth, it is incisors and canines. Class fourth, caries cavities that is localized on the proximal surfaces of anterior group of teeth, including cutting edge or angle of the tooth crown. And class 5, it is caries cavities that are localized on the cervical areas of all group of teeth. So on this slide, I propose to your attention the classification of caries cavities according to its complexity. So caries cavity can be simple, compound, and complex. So simple cavities, what is it? So it is cavity that involves only one tooth surface. Compound cavity, it is cavity involving two surfaces of tooth. Complex cavity, it is cavity that involves more than two surfaces of a tooth. When it goes about describing of two surfaces, the dentist in their hand noting, in their recording of in the dental chart, they usually use some abbreviations. And here is given abbreviations of two surfaces. If it goes about simple cavity, once again, I'm refreshing your knowledge that it is cavity that involves one tooth surface. We can describe this cavity in the following way. E, incisal, M, mesial, D, distal, B, buccal, O, occlusal, F, fascial surface is affected by tooth decay. Abbreviations of tooth surfaces for compound cavities. Compound cavities, it is that cavities that involve two tooth surfaces. Usually it goes in this way. The doctor can write DO, disto-occlusal, and please memorize how to pronounce these surfaces when it goes about description of what tooth surface is affected by tooth decay. So disto-occlusal, mesio-occlusal, disto-occlusal once again, mesio-incisal, distolingual, linguoincisal, distolingual, occlusobuccal. So here I have suggested to you structure of caries cavity. Without this knowledge, it is impossible to communicate with professional dentist. That's why such structure is available. So we have edges of the caries cavity. We have caries cavity walls, bottom here as well. Actually, what is bottom of caries cavity? It is that surface that is turned to a pulp. So it is bottom, and this is as well bottom, because pulp is below. Okay, it is compound cavity. In this cavity, we have main cavity. Main cavity, it is that cavity that is localized from the lesion surface. And additional cavity is over here on the occlusal surface. This cavity was designed to get access to the main cavity. So once again, I will repeat. So caries cavity has such structure. Edges of the caries cavity, edges, walls, bottom. If it goes about compound cavities, we give them such names. Main cavity, it is that cavity where caries was noticed, and additional extra cavity, it is that cavity that was designed to get access to the main cavity. Okay, we have successfully finished with the structure of caries cavities. And now we can go into Black's classification. So this classification was based on the knowledge and evidence that were available at the time of Black. It was early 20s of the 20th century and is still used today despite its limitations. And what is limitations? Limitations is such. It only refers to caries lesions and does not include root or secondary caries. Class 1. It is simple cavities. Class 1 refers to developmental cavities in pit and fissures of teeth located in occlusal surfaces of posterior teeth, buccal or lingual surfaces of molars, and lingual pits near the cingulum of the maxillary incisors. So it is class first. Second class, complex and compound. To this class refers cavities that is localized on proximal surfaces of posterior group of teeth. Complex because it affects two surfaces of the tooth, and compound because it affects more than two, three, and more surfaces of the tooth. Mesial, distal, and occlusal. Mesial and occlusal. Third class, simple cavities. This cavities is localized in the interproximal surfaces of anterior teeth. Class 4, compound cavities. These cavities affect interproximal surface of anterior teeth and include the incisal edge or cutting edge or angle of the tooth crown. So it is compound cavities. And class 5, it is simple cavities. They are localized on the cervical third of the facial or lingual surface of the tooth. It occurs because patient often sucks on sweets, or possibly it has bad oral hygiene. And do not be confused. At the beginning of 20th century were developed Black's classification. At the end of 20th century were added one more class, sixth class, but it is Simon's modification of Black classification. And these cavities are referred to simple cavities. But as here it is stated, it is not part of original standard classification. Actually, it is Simon's modification, I'm stressing once again. So, to these cavities refers cavities that develops on cutting edges, cusps, equator of the tooth. Actually, to these cavities belong non-caries lesions and caries that develops in a result of non-caries lesions, in a result of tooth wear, for example. The next step in our lecture goes about Black principles of cavity preparation. So Black suggested that it was necessary to remove additional tooth structure to gain access and visibility, remove all trace of demineralized enamel and dentine from the floor, walls, and margins of the cavity, make room for the insertion of the restorative material in sufficient bulk to provide strength, provide mechanical interlocking retentive designs, extend the cavity to self-cleansing areas to avoid recurrent caries. And now we have very essential question. What is cavity preparation? So preparation is aimed at dissection of decayed dental hard tissue in order to stop further progression of the caries process and the creation of the appropriate conditions for reliable fixing of filling material, restore anatomical shape and function of the tooth. And we have such principles of cavity preparation. The principle first goes about extension for prevention. It was suggested by Black. So, Black principle of cavity preparation is extension for prevention. And one more principle that is called biological suitability. It was developed by Lukomsky. It is totally opposite to the principle of Black. Objectives of cavity preparation: to remove diseased tissue as much as necessary and at the same time provides the protection to the pulp. To locate the margins of the restoration as conservative as possible. To ensure the cavity form, it should not be under the force of mastication of the tooth. To allow the functional placement of the restorative material. By the way, I would like to return back to this biological suitability. So actually, in this slide, it was given information of how to follow principle of extension for prevention. But I have said that biological suitability is totally opposite to Black principle, extension for prevention. And it means that cavity should be designed in such a way that as much as possible, healthy, vital tissues should be preserved. Actually, it is prohibited even due to this principle to cut excessive amount of dentine. Actually, it goes about cusps. Not to cut cusps if it is possible, if they are not decayed, because according to Black principles, even cusps should be cut. To follow the principle extension for prevention. to cut as much as possible to prevent progression of tooth decay. And now we will focus on common stages of dental hard tissues preparation. So, common stages of dental hard tissues preparation are such: anesthetizing, it is the first initial step to prevent pain and discomfort of the patient. The second step, it is disclosure, opening, and extension of caries cavity. Next, necroectomy. It can be total, partial. Necroectomy, it is removal of decayed tissues. Necro, it is something that is necrotic. Tomy, this suffix tomy means cut of something. The next step, formation of the caries cavity, given its certain shape, and finishing the edges of enamel, polishing them. So, anesthetizing should be selected according to the group of teeth and jawbone. For mandibular, it can be inferior alveolar nerve block. For maxillary teeth, the most used one technique in therapeutic dentistry for caries cavity preparation is infiltration anesthesia. Regional blocks should be omitted. The next step, disclosure. Pay attention to these photos. Here is given shapes of burrs and sizes of burrs that can be used for this procedure. So for disclosure, the most used burrs are round-shaped burrs, and as well can be used cylinder burrs. And arrows show the way how the burr should cut hanging edges of enamel in this case. And in this case, it goes about how the dentist can rotate a handpiece with a burr to cut hanging edges of enamel. And size, how to select size of the burr. First of all, the size of the burr should be appropriately chosen. It should not be too small or too big. It should be sufficient. It should, how to choose, it should fall into caries cavity. Easy fall into it and then cut. If it is too big, it is impossible to cut hanging edges. If it is too small, there will be perforations and it will not be comfortable to cut these hanging edges of enamel. So the size of the burr that is used for disclosure should be sufficient, as in this photo. It should fall into caries cavity easy. Necroectomy, it is removal of necrotic tissues from the caries cavity. It is the next step. It can be done with rotary instruments, with burrs, or with the hand instruments, excavators. Necroectomy can be total and partial. What is total? Total, it is complete removal of necrotic dentine from the walls and bottom of the cavity, and partial, it is complete removal of necrotic dentine only from walls and partly from the bottom of the cavity. So partial necroectomy permitted to be done in a case of deep tooth decay, if there is a possibility of pulp exposure. Total necroectomy, it is the most essential and the most desired technique to be done in tooth cavity preparation. So this photo shows how spoon excavator should be moved to cut necrotic dentine. Pay attention. From the center to the walls, excavator should be moved. From the center of the tooth cavity to the walls, not opposite. If it is done from the wall to the center, it is not sufficient cavity preparation. Moreover, dentine has tangential localization of its fibers. That's why this technique of necroectomy with excavator should be done only from center to the walls. Moreover, this will prevent from possible fracture of caries cavity wall. The next step in caries cavity preparation, it is formation of the caries cavity. Different burrs gives different shape to the caries cavity. This schematic representation shows what shape can be obtained if round burr is used. Pay attention to this photo. Cylinder, what shape cylinder burr gives? And inverted cone. Inverted cone basically is used to flatten the floor of the caries cavity and do some angles, right angles in the walls. So this burr is fits good for this purpose. Here we have steps, information of the caries cavity. Preparation of enamel, preparation of dentine, given to the cavity box shape. Actually, that is the principle of black, to give box shape to the cavity. Everywhere should be right angles under 90 degree. And for black, it was enough, but this diagram gives idea for modern caries cavity preparation. And according to the modern steps of cavity preparation, the final, what should be done, it is cutting of the enamel bevel under 45 degree. And this cavity is rounded. This is prepared for restoring this caries cavity with composite material. So here we have finishing of the edges of enamel. After opening, disclosure, necroectomy, formation of the caries cavity were done. The final step, it is finishing the edges of enamel with small cylinder burr or fissure burr. This is done under the degree of 45. Okay, let's stop on rules of the caries cavity preparation by Black. So according to Black, at his age, at that age when the classification was designed, enamel edges should be straight and smooth. They should not be cut with 45-degree bevel. Should be straight and smooth. Transition of one wall into another should be with 90 degree. General shape for the caries cavity according to Black principles should be box shaped. Transition of the bottom of the cavity to the side wall should be at right angle. And what is more important, bottom of the caries cavity should be flat or somewhat remind form of the occlusal cavity. It was permitted in deep cavities. So it is classical standards of caries cavity preparation by Black. This slide summarizes everything what we have discussed before about steps of caries cavity preparation. And let's summarize it. So caries cavity preparation has such steps. Disclosure of caries cavity is done with round-shaped burr, fissure burr, or cone-shaped burr. Caries cavity enlargement is done with the same shape burrs, but of course bigger sizes. The next step, it is necroectomy. Necroectomy, removal of necrotic tissues, is done with excavator, manual instrument, and rotary instrument burrs of different sizes. But this is round-shaped burrs for necroectomy we use. Shaping of caries cavity. To obtain straight walls, flat bottom, should be used such burrs as inverted cone, wheel-shaped, round-shaped. Inverted cone can be used to shape floor of the caries cavity and walls at the same time. Wheel-shaped is used to flatten floor of the caries cavity. Here can be used cylinder as well for walls to make them flat and straight. And actually, these are varieties of retention points for second-class cavities and for the first-class cavities. As in the era of Black, restorative materials do not possess any adhesive properties. At his era, only cements were available, and cements do not have any adhesion, chemical adhesion, except of mechanical adhesion. And mechanical adhesion can be obtained if there is appropriately done retentive points where cement can flow, and due to these retentive points, it can be kept there for a long time. And here you have burrs and retentive points that they can do indentine to keep the material inside the caries cavity. And final stage of caries cavity preparation, it is smoothing and finishing of enamel edges. Here should be used burrs for polishing with finest diamond grit or with very small cutting blades. Such burrs that will not destroy enamel too much. So burrs for smoothing and polishing, it is separately used, they are separate from that is used for necroectomy and for caries cavity formation. They have another type of coating material on them. And now we are on peculiarities. Before we have discussed general principles of Black classes preparation, and now we will stop on peculiarities, as every class by Black has its special features of preparation. So this photo shows the peculiarities of first and fifth Black classes preparation. So here it is just caries cavities, where they can be located and what shape could they have. And here we have prepared, ready, formed caries cavities after preparation. Two cavities on the occlusal surface and on the labial or buccal surface in the pit can be prepared separately, as in this case, or if the great amount of dentine is destroyed, such cavities can be compounded together, and in this case we call them complex. And here we have different shapes, possible shapes that can be used, can be prepared, dependent from the affected area of the tooth crown. And the fifth class by Black, the shape of this cavity is kidney-shaped or oval. The bottom wall, actually this wall that is close to the gums, should resemble the gum line. And pay attention, if it is first class by Black, here we have straight walls, flat bottom, shape of cavity resembles rectangular, but in this case, it is peculiarity actually of the fifth class by Black, fifth. It is oval or kidney shaped. And look on this cross section. Pay attention to the bottom floor of the caries cavity. It is not straight, it is convex. It resembles the pulp chamber. In the first class, it is straight, but in the fifth class, it is convex, because it should resemble the pulp chamber, as in the cervical area, dentine is thinner, as in the equator of the tooth or occlusal surface, and in the fifth class by Black, there is a possibility of perforation of pulp chamber. That's why the bottom should be convex. According to Black's preparation, a cavity of the first class should be with straight walls at right angle to the bottom. A shape of the cavity could be cylindrical, square, rhombic, X-like. According to Black's preparation, a cavity of the fifth class should be in an oval shape, walls and the bottom should be at the right angle. Bottom is convex because of pulp proximity and cervical area, thus prevented pulp exposure. Peculiarities of second-class preparation. Here it goes about localization of the caries cavity. If the caries cavity is localized above equator, we give it such rectangular shape. If it is localized below equator, it is given shape of stairs. I will refresh your knowledge that equator, it is the most prominent part of the tooth crown. And actually here we have contact point in this part where we have prominent part of the tooth crown, equator. It is the middle of the tooth crown, equator. And in a case if there is no neighboring tooth, close standing tooth, caries cavity can be prepared without extra cavity. Just prepare it as a rectangular, not cutting occlusal surface. Just fall into this cavity directly from the site of lesion, if there is no neighboring tooth. But second-class cavity, as I have said before, has main cavity and extra cavity. Main cavity, it is that cavity that is localized in the area of lesion, it is proximal surface, and extra cavity, it is that cavity that is prepared first to get access to the proximal surface. By the way, in the era of Black, I will repeat once again, there were no adhesive materials. That's why to keep material inside the tooth, He suggested to shape additional cavities in such special shapes. The most favorite one was dovetail. Here it is shown, dovetail. As well, these can be designed if necessary. So numerous shapes could be done just to keep the material inside the caries cavity. According to Black's preparation, a cavity of the second class should be: if there is no neighboring tooth and the caries cavity is localized below the equator, it is formed on the proximal surface. When excess is complicated, a cavity is extended to the occlusal surface and additional cavity is formed there. Additional cavity occupies the 1/3, 1/4 length of the occlusal surface. And we have peculiarities of caries cavity disclosure of the second class according to Black preparation. Excess is gained from unaffected occlusal surface. So these are peculiarities of second class preparation according to Black principles. Preparation of third and fourth classes by Black. It is cavity that is localized on the proximal surfaces of anterior teeth. Here we have the tooth decay, here we have shaped caries cavity in the form of triangle. So the general shape of third class cavities is triangle. For first class it is rectangular, for second class it is in general stairs or rectangular if it is above equator. And third class it is triangular, fifth class oval. So third class. Pay attention to this peculiarity. If there is possible extension of tooth decay to the whole proximal surface and somewhat affected palatal surface, it is advised to cut cavity in such way to extend it to the palatal aspect to prevent tooth decay. Pay attention to this shape of the caries cavity. And fourth class by Black. The cavities that is localized in the proximal area of anterior group of teeth affecting angle or cutting edge of the tooth. Access to such cavities, as well as access to third class cavities, can be done and should be done from palatal or lingual aspects, not from the labial surfaces, because it will not be aesthetic. Pay attention to these extra cavities, their shapes, dovetail or just like a fissure or somewhat, some retentive point just to keep the material in the proximal area. But if it goes about restoration of anterior teeth in the era of Black, once again I'm stressing on this, at that time there was no adhesive materials, only cements. So at that time it was suggested to use dentine pins, such armamentarium, as here it is shown, to restore angle of the tooth crown. They were extra support of material, such kind of armamentarium. But modern dentistry suggests raising composites, light curing materials, and they have good adhesion, so there is no necessity to use these dentine pins. That is the benefit of modern dentistry, actually. And according to Black's preparation, a cavity of the third class should be with the shape of triangle. If teeth are stand tightly one to another, it is extended to the lingual surface and an additional cavity is formed there. disclosure of a caries cavity of the third class according to black preparation is done, and excess is gained from a lingual surface, in some rare cases from labial surface, but lingual is preferred. According to black preparation, a cavity of the fourth class should be an additional cavity is formed either in the area of incisal edge when it is wide, or on the palatal lingual surface within the limits of dentine. We have finished with black principles preparation and peculiarities of black principles preparation, and now we are on a new question, caries cavity preparation for restoring them with composite material. And right now I will say very interesting statement. Here we will talk totally opposite. In a black principle, I have said that everything should be straight. Walls, floor, edges, like a box. If it goes about restoration with composite material, free shape is available. Bottom, rounded, edges is cut under 45 degree. In general, cavity can be given different shape, whatever shape, such shape that only cuts decayed tissues, not cutting healthy tissues. And this is example. So tooth decay in occlusal surface in fissures, and this is cavity prepared for restoring with composite material. Such shape, free shape, no special design, just cut of decay tissues. Here it is after etching with etch and gel. It is white porous. And here it is after restoration with resin light cure material. This lecture devoted not only to traditional ways of cavity preparation using burrs, but also it is devoted to some new techniques, so-called atraumatic restorative treatment techniques. And ART technique, for example, it is such method in which we do not use burrs, just excavator is used to cut decayed tissues. And later, this cavity is restored with glass ionomer cement. Because glass ionomer cement do not demand any special cavity preparation except of caries removal. Moreover, this material has anti-caries activity, so if there is some traces of tooth decay possibly is left, still they will be remineralized and microorganisms cannot survive and cannot progress with glass ionomer cement. They will be killed because glass ionomer cement has alkaline pH, has fluoride in its composition, and microorganisms cannot live in such environment. They will be destroyed. And this atraumatic restorative treatment is advocated for such patients who are afraid of this special sound from handpieces, the first. Second, there is no ability to provide normal caries cavity preparation because there is no electricity or there is no dental units in some areas that is hard to reach, for example. But patients have tooth decay and it is necessary to provide some treatment. And finally, a traumatic restorative treatment in majority of cases is advocated for children. It's essential because children usually have some not understanding of what to do with this sound from the handpiece. And it's easy for them to stand with just manual cavity preparation. And this atraumatic restorative treatment goes into the category minimal intervention dentistry. Atraumatic restorative treatment together with caries solve technique, heal ozone, is used. It is something like it is like a compromise. We have surgical management of tooth decay and non-surgical management. So actually minimal intervention dentistry, it is non-surgical management of tooth decay. So airtight technique I have discussed. Caries solve, another possible option that can be used. The technique is very similar, but it is brand name and special brand instruments are developed and special liquid is used for this treatment procedure. At first, tooth decay is removed with caries solve gel. Caries solve gel, it is some amount of sodium hypochlorite liquid, some sodium hypochlorite gel that dissolves necrotic tissue, and then special instrument, very similar to excavator, but it is brand name, is used to cut this dissolved necrotic tissue. And after that, restoration was any restorative material, but the most used one is glass ionomer. Heal ozone method. Caries treatment with ozone is based on the fact that the certain concentration and exposure time of ozone kills cariogenic bacteria without affecting healthy cells. Air abrasion. It is also called kinetic cavity preparation. Particle beam or kinetic abrasion technology uses the kinetic energy of microfine particles of alumina in a high-pressure air stream to remove tooth structure by brittle microfracture. Technique of air abrasion is described here. Using air abrasive unit with high volume evacuation placed in the proximity of the caries cavity. After a few seconds of initial preparation, examine the preparation for decay. Reapply caries detecting dye. Complete the preparation using the caries detector until all caries is removed. Air abrasion used to remove and restore peat and fissure caries using 27 micron sized powder particles. Fissure caries seen on occlusal surface of mandibula, second molar. Tip of air abrasion device placed on the molar. Removal of caries with minimal cavity preparation bits. And final restoration of it. Advantages and disadvantages of air abrasion. Advantages. Reduced need for local anesthesia as well as a reduction in the annoyance factor for the patient. However, the use of rubber dam is strongly recommended to help control the distribution and inhalation of the dust. Disadvantages. Air abrasion will not effectively remove the smear layer from dentine, but rather creates one. Acid etchant should be used to remove the smear layer prior to bonding of resins to dentine. However, it must be noted that large areas of softened infected dentine are not hard and brittle, so it has limited ability to undergo brittle fracture. Laser use in conservative dentistry. The use of lasers not only help in providing effective preventive dental treatments, but it also helps in reducing the patient's anxiety and incorporating patient-friendly approaches to dental care. And here are some of the preventive dental treatments that employ lasers. This table gives information about mostly used lasers in dentistry. They are carbon dioxide, neodymium doped yttrium aluminium garnet erbium diode laser. Erbium lasers has the function to provide caries removal and cavity preparation in both enamel and dentine, and they can be used in preparation of root canals. Other lasers basically used for soft tissue procedures: gingivectomy, frenectomy, treatment of ulcers, aesthetic contouring of gingiva. Diode laser as well can be used for tooth bleaching procedures. Caries cavity preparation with laser, erbium lasers, and erbium chromium machines are multi-tissue lasers with extremely short pulses and high peak power, allow for efficient enamel and dentine photoacoustic ablation. Erbium lasers can prepare all classes of restorations. Many restorations can be accomplished without local anesthesia. In conclusion, it can be stated that, however, the purely surgical approach to caries control, as taught by Green, Vardim, and Black, is now recognized as being far too destructive to be used as the first line of defense. Still, it is taught as a gold standard of cavity preparation and is used as a base to modern methods and techniques of caries treatment. That is why dental practitioners should be familiar with the modern principles of treatment options of dental diseases and then choose the most suitable in a certain clinical case. The final statement, it is practice makes perfect. The more we do a skill or activity, the better and more proficient we are on it. So references to this lecture are such: Wolfer's Dental Anatomy, Lasers in Dentistry, Current Concepts, Pickard's Manual of Operative Dentistry, and Studeward's Art and Science of Operative Dentistry.